So we're up to presentation 7. I'm sure we've all found it an absolutely fascinating morning so far. So I hope you enjoyed your plenary session, or your parallel session rather, before we came back in. So now we're going to look at the impact of adult behaviours, conditions and circumstances on child health outcomes. And we're going to hear a practitioner's voice. I'm going to invite Dr. Kerry Milligan up to speak with us, who has been based in Greater Glasgow and Clyde, but has a lot of experience around the area and wants to share a lot of that personal practice expertise with us this afternoon. Thank you.
Thank you very much for asking me to come along and share some of my experience with you. I have worked within the homeless service for about 15 years now. I currently I helped develop and expand what was the homeless family service, which is a team of health visitors, myself, a nursery nurse and a midwife. And we're now part of a bigger service in Glasgow serving the homeless population, so adults and families. And we have a mental health team and an addiction team, psychiatrists, OTs. So we are a big team. And I think we've learnt a lot about how to work well together with a population group that, to be fair, have not been served well. So I think that I've got something to share. I'm a little bit conscious that my presentation is a little bit more downbeat to begin with than some of the presentations that we've heard so far this morning, but I do end on a more positive note about what I think that does work quite well, so bear with me. I think for me as a practitioner, our patients tell us lots, and I think it's really important that we learn from our patients and that we listen to them. And I thought I'd tell you about Jason. Obviously the names of the patients I'm talking about today, their names and their stories have been slightly tweaked to protect them, but the principles are exactly the same. And Jason came to see me as an adult patient, and he'd been homeless for a while. He'd been sleeping rough. He had not managed to maintain his tenancy over a couple of years, and of course he inevitably hadn't had any health contact for about 3 or 4 years. He had chronic anxiety and social phobia and really struggled to communicate and to interact and interface with professionals and his own family. And he used alcohol greatly. You know, he would have a drink before he came to see me. It helped with his anxiety. But the main reason he came to see me was, he was like, "Doctor, I need a mental health assessment because I need to see my children. And I've been told if I don't get a mental health assessment, I can't see my children." And I thought, gosh, you know, this is going to be really complicated and really difficult. And we then got Jason's records, and I think that this is quite a common scenario for me in the homeless practice. In fact, I could almost write their chronology before I open the record. And Jason, as a child, experienced a great number of adverse life events. You know, he in early years presented with developmental delay. He had lots of behavioural problems. He was difficult to comfort. He was difficult to feed. He struggled at nursery. He was bullied because some of his health care was not attended to. He had big gaps in his education, partly because he lived with different relatives over a period of time, and partly he was accommodated on occasion, and of course that leads to disruption in your learning. He had great difficulties socialising, great difficulties making friends at school and with peers, and really was very untrusting as a child. Now, the background to his circumstances was he lived in a very neglectful family. There was a lot of parental substance misuse. It peaked and troughed. There were periods where parenting was very good, and then there were periods where the parenting was very, very poor, which ultimately led to periods in care for Jason. Now, that is not a good story. It's not a good history. And that is partly why we're here today. And I think that, you know, if there's one thing I can do for Jason is to share that, and that we all learn from our patients' stories. I think I'm also quite interested in involvement with the criminal justice service. We have a lot of patients who are involved with the criminal justice process, or indeed have served custodial sentences, and many of them come back out from prison and become homeless. And we know, particularly looking at women, that there are a high instance of both mental health problems and drug misuse problems. 37% of women in Corton Vale have been in care as a child. So we really need to begin to break that cycle. We really need to break the cycle of the neglect that some of our children experience, and the huge impact that then has on adulthood. And these adults then become parents themselves. And the cycle goes round and round and round. sorry, that hasn't come out very well, but 2/3 of the women in prison have got children, and only 17% of those children live with their father. So that's 83% of those children living with somebody else. Now, straight away, those children's outcomes are going to be poor. Their attachment is going to be poor, their development is going to be poor, their educational attainment is going to be poor, and so the cycle continues again. Again, I'm sorry, this seems quite depressing to start with. It does get better, honestly. Significant case review. We will all be familiar with the very public significant case reviews that we see in the media and that sometimes scare us, and when we think, gosh, I'm glad I wasn't that practitioner involved with that one. And we know about the toxic trio, we know about the impact of parental substance misuse and mental health and violence on children's lives. But again, for me, what is really important is 1/3 of these parents had troubled childhoods. And I think that's sometimes the fact that does get a little bit lost in some of the analysis. We're very blaming sometimes of parents, but actually we have set them up to fail, and we must do better with that. I think neglect particularly has become, certainly in Glasgow and Clyde, the thing that we struggle with the most, partly due to the sheer volume of it, and partly due to the complex nature in which neglect presents itself to us. The more complex the family you have, the more likely you will have lots and lots of workers involved with your care, and therefore it's very difficult to coordinate that and make sure that we don't miss the children who are slipping through our nets. And we need to identify children earlier, and I think the GIRFEC framework allows us to do that very, very well. I think we've also looked at specific cases in Glasgow and around neglect, and I think that the lesson we learnt from that is that we are just not responding quick enough for the reasons I've just described. We are allowing children to live in circumstances that are unacceptable. We are not sharing information. We are not recognising well-being as well as we could. Some of us are, and then we're sharing it with the wrong person, and some of us don't recognise it. And sometimes we're very optimistic as well, and I think sometimes we need to sometimes review and reflect on the information that we see in front of us to make sure that we're not actually missing a child who needs our support and care. So we're going to get more positive now. What has changed and what does work well? Because there are lots of positive models of help and support out there. I mean, there are lots and lots of stands there, very, very proactive, really good work, and that all needs to get shared. There are things out there that I have never heard of, never known about, and I think that's really important. I need to go away and have a think about that and think about, I was also reflecting on the presentation about the third sector and how we can get caught up in our own silos and not actually look wider than that and look for help ourselves. It's not just about helping our patients, it's about helping ourselves to help our patients. I was clearing out my desk because some of you will know that we're all moving to this super hospital in Glasgow, to the Death Star, and I was emptying my desk because I'm only allowed one box, and so I've got piles and piles and piles of books. I really need to downsize. I've only got one cardboard box. And I came across the good working practice from 2003 of working with families affected by parental substance misuse. And I thought, that's really interesting because that's the sort of thing that we're actually going to do much, much better now. And I thought it was really interesting, those statements around what wasn't working and what were the difficulties for staff that actually we don't really understand, or at 2003, we didn't really understand what other agencies did. We didn't understand their job. We didn't understand what they were going to do for families. The whole minefield of information sharing and consent and the difficulties that brought with it. And certainly in general practice, we still at times struggle with that. I think things have hugely changed, but I still think at times we struggle with it. So again, to have much clearer guidance and support professionally around that makes such a huge difference when we're talking about lower level concerns, which is what we're generally talking about today. And again, this perception that we've got different legislation and different policies and we're different assessments and different paperwork, and you use paper and I use IT, and the whole thing actually, when you look back, was a bit of a guddle, and it's not surprising that at times we didn't quite get that right. I think also I was reflecting on the named person, because that's often quite a common comment from GPs, and they'll say, particularly about school-age children, I don't really know who to let know. I don't know who to give that bit of information to. I love it when it's an under 5 because I just tell my health visitor and that's great. So again, the named person offering us a real opportunity to recognise who we can share information with, why we're sharing the information, and that actually that person that we share information does have a responsibility, as do we, but that there will be some structure around what we're able to do. And I thought that that's a nice quote from Monroe, and actually that was identified for us, and we've certainly picked up that baton in Scotland in terms of what it is we can do for children. I think interventions, you know, there's the identification of the children who need a little bit extra care and support, and it's then, you know, what do we do for children? And I obviously work in child protection a lot of the time, and again, we do get caught up in acute crisis management and putting something in place that actually for sometimes is only for a very short period of time. Children need sticky workers, vulnerable adults need sticky workers to stick with them for longer periods of time to make change. I think that's easier when you're identified earlier, and parents are going to have a more positive relationship with you, and they don't see it as just child protection all the time. I think it needs to be early intervention and for longer periods of time. My own specialty, general practice, for those who know me very well, I am an absolute flyer of the flag of primary care having an absolute central role in the identification and support of vulnerable families. We are absolutely best placed to do a lot of that work. We have lots of regular contacts with families over a period of time, and I think Jenny Woodman's work through NSPCC and UCL is fantastic in terms of describing that and really supporting the framework that GPs particularly and attached staff can think about when they're thinking about what they do. Sometimes general practitioners and other staff don't recognise that actually their contacts with families in themselves are therapeutic and are actually interventions. You know, sometimes it doesn't have to be something that's particularly fancy. You know, listening to families, supporting them, guiding them, signposting them, asking to see them again, and having a bit of continuity of care for some families is very, very powerful. And I think we're also best placed to manage a lot of children who are not going to reach the threshold for formal child protection input. And actually, we don't really want all our children to have to reach that threshold. There is lots and lots that we can do in the work that we do with families that is supportive. A little bit about what I was thinking about what I do in the homeless practice that I think that works well. And these are just some reflections around what we do. Some of it will be well known to you, but I think we all think family, think parent, think child. I mean, the whole thing comes together. I also put that back now to children's workers to also think family, think adult, because actually, you know, the intervention or the support has to be for the family and not for the individual. And I think we all need to be mindful of that. I think we've developed a culture where staff will particularly come in and see me and say, can I just let you know, they're not waiting for that monumental event that they know is child protection or hugely significant. It's a bit of an open door policy. Come on in, what is it? And I'll say, oh, that's interesting. I just saw them the other day. And the dialogue is much more informal and I think much more helpful for the children and families and for the adults that we serve. We do a lot of our training together, and again, some of you will recognise that and would appreciate that. And I think that is always quite important. And this is obviously a mixed audience today, and I think it's really important that we learn and discover together. It helps us build relationships. It helps us trust other agencies and trust other professionals, even within our own agency. And again, it leads to this sharing of good practice and actually feeling safe when people want to challenge and scrutinise what we do, because it's actually, we should allow that to happen. We should be able for people to come up and say, actually, Kerry, do you know what? I don't quite agree with that. Can I ask you about that? Do you not think we should change our mind or do something different? And we mustn't get stuck in the rut that once I've decided that it's one thing, that it's not going to change into something else. And I think we have to allow ourselves to feel that we can challenge things. So I'm going to end up with two cases that I think are quite positive. This was a case, actually, the first one came in through the Child Protection Unit advice line. And it came from a GP, and she had been contacted by the school, and she was slightly taken aback. The education phoned me and they want some information. And I said, oh, that's fine, tell me about that. And she said, it's because the school nurse is off and it's the holidays. And I think the school had phoned the team leader. And the team leader said, just phone the GP. So, of course, it did put the GP slightly on the spot, but I thought that was a very good thing, because actually they were the person who had all the information about the family. The school were concerned that Mark had some recurrent head lice and wasn't just presenting particularly well, and they wanted to know if anything was happening at home that might account for his slight change in presentation. And the GP was saying, it's not child protection. And I said, right, okay, I know it's not child protection, but actually that's a change in that child's circumstances, and I think that's really important. Why don't you go away and speak to your health visitor and find out a bit more information? And Dad's not registered at our practice. And I said, that's okay, go away and speak to the other GP. And of course she came back with this chronology, and we can all sit and look at that and think, oh yes, there's lots going on in that family. But I think it was a real eye-opener for that GP in terms of actually it doesn't need to be child protection, and actually there are lots of bits of information out there, and if I take the time to pull it together, it will give me a much fuller picture. And of course what happened was Mark and Kirsty got additional help and support. And actually the adult workers working with the families slightly shifted the way that they worked with the parents, and a much more focus on family work and the impact that mental health and addiction can have on children. And that I thought was a really positive outcome for those children. This is a slightly more complicated case, but again, I think for me, it highlighted how important it is to work together. Bobby is about 2.5, and he had been living in another part of the UK, and was completely below the radar of any services really, and he came up and was put in homeless accommodation that has sort of got this sort of semi-supported accommodation, and the housing officer said, something not right with that mum, she's talking to that buggy and she's just not quite right. So of course our health visitor and nursing nurse went out, and absolutely there were quite a number of concerns about mum's mental health, but she'd been looking after Bobby for 2.5 years without additional support. So we asked Mum and Bobby to come in on the Monday morning to see me, and the slight luxury that I have was that Mum and Bobby were able to see me and the nursing nurse and the health visitor and the CPN and the psychiatrist. So I really, I think, a good service, a good assessment of family life for Bobby and his mum. And yes, Mum was diagnosed with a psychotic illness that she'd been slightly medicating with street methadone. And I know that sounds quite serious and significant, but actually we decided to put a bit of a package of care around Mum rather than seeking to accommodate Bobby, because we actually felt that we could work with Mum. She was unwell, and with care going in twice a day and support from ourselves, we thought that we could probably shift the outcomes for Bobby. Now, unfortunately, Mum's mental health did deteriorate slightly, and he was accommodated inevitably over the Easter weekend. But what has also happened is that Mum has a really positive relationship with us. She still comes to see us, she still engages because she recognises us, she trusts us. She is able to speak to the CPN whenever she wants to, and in fact the CPN that we have has done her child protection certificate and is really good at working with families and helping assess and look at parental-child interactions, and I think that's a really positive thing. So while Bobby is accommodated, actually his relationship with Mum is strengthening, and we're doing play work with Bobby at Contact through our nursing nurse and our CPN. And actually, I think, again, that is a way of kind of bringing all the workers together and having a bit of a core understanding about family life and the things that are important to Bobby and to his mum. So thank you for listening to me. And I hope it wasn't too downbeat to begin with, and that you understand a little bit about what I do, I suppose, and that's the main thing. Thank you.